thank you everybody for attending. I was really afraid when I started doing this that it would be me, my parents and my sisters and my wife in this big room. So thank you everybody for attending. So I've worked for the University of Bristol 10 years now. So it's exactly this year, which is quite nice, I thought, to do my inaugural lecture at the same time. When I started talking about this, I had this idea that I wanted to talk about, but everybody just asked, can we see photos from when you were younger, and can you tell us how you got here? So that's kind of what I'll start with, but I do have some actual sciencey stuff as well. I'm sure it's no surprise to anybody that doesn't work. So I was going to pick this up from the moment that I got my PhD at Utrecht University in the Netherlands. This is what a PhD defense looks like in the Netherlands. I started my PhD as looking at the rubber manufacturing industry and measuring chemical exposures, being in factories, measuring exposure, modeling exposure, and making that useful for future epidemiology. But on the side, I did some additional work. I did randomized controlled trials with MR engineers. This is one of those MR engineers, where we looked at neurobehavioral effects of people working around MRI scanners. And I did that on the side while doing my PhD. Nobody talked about the rubber manufacturing, but they did talk about the MRI work and the neurobehavioral effects of that. So at the last year of my PhD, we decided to switch topics. So I had worked 4 years on one topic, we switched to the other one, and my final PhD was around neurobehavioral effects of MRI scanners, so static magnetic fields. And this is what my PhD thesis looked like. I was very proud of the front of it. Now it looks a bit early 2000s, but I designed it myself at the time. And the motto of my thesis was the plan. It wasn't much of a plan. I just started working, which I think is something that accidentally has followed me around, and I'll talk about that along the way. After I finished my PhD, I went to Lyon, where I worked at the International Agency for Research on Cancer. This is me bossing a 15-year younger French person. And I worked there, I continued to do occupational epidemiology and occupational health. But in this particular case, in asphalt paving. So these are photos we took during the field work. And you can appreciate that first in the rubber manufacturing industry, then in the asphalt paving and indoor asphalt paving, that I'm not, I'm not unknown to getting a bit of air pollution myself. That's where these photos come from. So after my fellowship ended, I moved to the University of Manchester, where I worked in occupational health still, but I also started to work in more environmental health, and I did the first little bit around air pollution and public health, and that's kind of where my work on public health started. Some things happen work-related, other things happen not work-related. So I met my now wife in Manchester. She got a job in Bristol and told me that it was a good idea for me to move to Bristol as well. So here I am. That's 10 years ago. But along the line, and in Bristol I started to really work. So I started at the Center for Public Health, and that's where I got involved in public health research and doing things I'd never encountered before, qualitative research, process evaluation. So there was quite a lot of new stuff for me to learn, and I'm still kind of learning that. I continue to do work around occupational health, environmental health, public health. I learned what Bayesian statistics were, and so I did all these kind of different things, and I put that all together in a word cloud, just to show all the different things, and the bit that I I kind of do all the stuff I kind of find interesting, and that's, when you do that, that's what you end up with. So I was in Bristol. I'd done all these kind of different kinds of work and all these different things, and I thought an inaugural lecture like this is probably quite good to give advice to junior colleagues on how to become a professor and how you do it like a career. And the only thing I can come up with is to say, just say yes to pretty much anything that comes along, and hope for the best along the way. And I appreciate that that's awful advice, but it's really the only thing I can give you as advice. And when you do that, some people, and I was lucky enough, eventually become a professor. And not just that, some people also manage to publish papers with their little sister along the way. So these are two papers I wrote with my sister as well. Despite doing all these things, there have been two threads through my career that I continuously have been interested in. One was radiation protection. So I'm on a number of national and international government advisory bodies or expert committees around radiation, and I managed to make it onto the BBC in England a couple of times as well along that. And the other one is around the methodology of how you evaluate interventions or policies. How do you know something works if you put in a public health policy? Or how do you know, for example, whether mobile phones are related to brain cancer? It's those kind of things, and how do you do the methodology for that? So in a way, what that is really what do you call it? The boring bit of science that I'm interested in. Now, it's this bit kind of that I want to talk about here, that I want to take the opportunity to, because I've worked in all these different fields, a little bit in lots of different fields, and one of the things, without fail, that happened was the fact that the main risk factor for any disease happens to be the one that's in the field that you're in. And that has made me, and I think that's something that has come to define me, and which will go forward in my talk, is I'm quite suspicious of new unexpected results or things, big effects of interventions, for example, but also things called paradigm shifts. I get a shiver down my spine, and I'm almost sure that I shouldn't be trusting them. And that's, I think, quite an important bit, and that's something I want to take forward in the rest of this talk. So the rest of the talk will have some examples of studies we've done in the Center for Public Health. And I have taken all the names of people that are involved in the research. I've taken them all out because the presentation would be much longer, but also I'd be probably forgetting people, and then people would be angry, etc. So I've taken it all out, but if you recognize your study, then thank you very much for working on the study with me. To talk about research methodology, and I'm sorry that I lured you all here to talk about research methodology rather than a paradigm shift. But we need to go back a bit and do a bit of theory. And the way normally, traditionally, you would evaluate an intervention is you have a group of people, you randomize them to an intervention policy, and or the other group not. So either they have no intervention, a placebo, or usual care, and then you compare the results in terms of, say, incidence of a certain disease, and you check whether there's a difference. That's the top bit of this graph. Now, another way how you can do this is you can look just at populations, and you can look at incidence of some kind of health effects, and then some kind of exposure that you think is linked to it, and you look at correlations between the two. So, for example, the incidence of COVID-19 and vaccinations or mask wearing, and you could do those kind of things as well and see what happens. So that's traditionally what public health researchers used to do. You used to do it interventional, so the randomized controlled trial, or you would look at population data. Now, more recently, they've gotten more interested in something else, a combination of the two, where you can't do a randomized controlled trial for a variety of reasons, ethical or other, but you want to get better data than just observational data. And the way to do that is you have a group of people and something changes in their exposure, for example, a new policy or a public health intervention, and you measure them before and then you measure them after, and that's a little bit what you see at the bottom slide. So you don't randomize an intervention, but something happens, and you can see that in the timeline. And then you have a control group that wasn't exposed and another group that was exposed, and you look at the difference. And the fact that you specifically look at that change in exposure in relation to a subsequent change in health effect makes it stronger than a normal observational study, generally speaking, but possibly not as strong as an RCT because you didn't randomize this as a researcher. So that's kind of my interest and the interest of public health evaluation in the last couple of years more broadly. And to give an example of one of the most famous ones, this is John Snow. Both of these people are John Snow, only the top one is of relevance. And John Snow was a physician, and this is in relation to the cholera epidemic in London of 1854. He is most or best known for, at the end of that epidemic, removing the handle of the Broad Street pump in Soho and saying, okay, if this is removed, you guys can't drink contaminated water anymore, because his hypothesis was that cholera transmitted through water rather than through bad air, miasma. That incident of this pump was interesting and it was a bit circumstantial, and not everybody believed that. So we had to do something better, and he used statistics for that. And that's described here a little bit in graphical form. So that's a map of London, and there were two water companies, the Southwark and Vauxhall company in blue, and they serviced the people in the blue area, and the Lambeth company in red, they served the red area. But there's one area where they overlap, and that's that darkish colory thing. That's a really interesting area because each house could be serviced by one of the two companies. And that was done by landlords. It could differ from one house to the next. And because it was done by landlords, people didn't know who serviced them, nor was there a systematic difference between the populations because they were living in the same streets, had the same jobs, same incomes, etc. Now, the interesting thing here was that the cholera rates were fivefold different between the people in the serviced by the Southwark company, the blue company. They were 5 times higher compared to the red one, the Lambeth company, despite everything else being the same. The only difference was in the previous cholera epidemic from 1849, they both had their water intake near the Vauxhall sewer, and so they both got contaminated water. Since then, the blue company, so the Southwark company, didn't make any changes. They still got their water out of that same area, but the Lambeth company had changed it upstream to where there was clean water coming in from before it went all through London. And so that change is a change in exposure. That explains why the rates were the same in the 1849 epidemic, but they were vastly different in the second one. That's very strong evidence, and that's kind of what natural experiment evaluations are. So that's what they're called. They're called natural experiment evaluations. And that's the kind of stuff we are interested in doing. We're not the only ones doing that. This is from a paper we did where we looked at all place-based evaluations, or public health evaluations that used a natural experiment design in the last 30 years. And what you can see is a massive increase in the use of these kind of designs, especially since that dotted line, which is the MRC guidelines for that, there's been an increase in these kind of things. So a lot of people start doing this kind of work. So my colleagues and I in Bristol do this kind of work as well. We look at specific practical examples, but we also look at methodology and how do you improve these. We mostly do that in the context of NIHR funding framework. So I work for the NIHR School for Public Health Research, where we do a lot of this kind of work. The NIHR Public Health Intervention Response Teams, which is based on this kind of thing. And also the Applied Research Collaboration West, where we look at these kind of things as well. So what I would like to do is discuss a couple of these in a more practical way, and just show what they're about and what their problems are. So I could have included quite a lot of them, but I think an interesting one is that of alcohol licensing done by councils, which is the kind of work that I started doing when I moved from Manchester to Bristol. And my first job, in a way, was to look at these kinds of, to look at the question, what if local councils have certain measures through licensing to curb the negative impacts of alcohol, so in relation to health, but also in relation to crime, and they can do these kind of things, but do they actually work? That was the question we were tasked with. And first we did the old thing in a way. So we looked at observational data, and what we did is we developed a metric where at the first year where we had data for all of England, we looked at how strict they were in their alcohol licensing policies, and that's the figure on the top left there, and the darker the stricter. And what we wanted to see is, if you're stricter than as a local council than in other areas in England, is there a bigger impact on alcohol-related hospital admissions, for example, and local crime? So we did these analysis over about a 10-year time series, and it turned out if you had stricter policies, then yes, at the end of the time series, you had about 2 to 8% lower crime incidence and lower incidence of alcohol-related hospital admissions. So that was quite useful evidence. That was the first time that was done. That made the newspapers and was quite useful for policymakers to use in how they design their alcohol licensing policies. But this is observational epidemiology, so lots of other stuff could have happened along the way, and there could be loads of reasons why you see that. So we wanted stronger evidence, and that's when we started to look at more at the natural experiment. And we thought, actually, what happens in these things is some of these outcomes, especially crimes, but some of the health outcomes as well, if you make a big change in the exposure, so a big change in the policy, you go from doing very little to doing a lot suddenly. For example, because a new framework comes in that you want to use. Then the response, these certain crimes and certain hospital admissions, would also start to change immediately after. And you could look at that and see whether that made an effect. So we did that. We found 5 areas in England where exactly in the middle of our time series, in around 2011, they switched up from nothing to a lot in this particular year. We looked at those and we can compare that with the other areas where nothing changed. And we found something similar. We found about a 5% decrease, which is roughly what we had in the original study, and this kind of confirmed it. Now, importantly, we did those same analysis, but for other areas where nothing changed, just to see if we would find nothing, which you would like. And we changed at different time point. We looked at different time points to see whether that effect was specific for that local area and that time point, in which case it was probably related to the policy change. And indeed, we didn't find anything for those things. So that brought us extra evidence, and not just extra evidence, it brought us stronger evidence that we can triangulate with the original study. And it all said the same thing, that these two things are related. So that worked out really well and tells you something why kind of these natural experiments are really useful. We then did this for individual premises as well. So we took it one step further and looked at, can you measure an effect if a problem club or bar, for example, in an area closes? And can you measure the effect? Because that would be really important for licensing cases for local councils. And we did that, and indeed you can, and we showed that for the closure of a big nightclub, that there was a massive drop in local crime for a couple of months, because the punters who were causing these troubles weren't going anymore. Unfortunately, after about 4, 5, 6 months, they slowly all came back, and the effect didn't work anymore. But it shows you kind of how these things work in complex systems. So that's kind of an outline of what natural experiments are, how they're used, and why they're more useful than a lot of, or why they can be more useful than a lot of other studies. And we've done quite a lot around COVID-19 pandemic, advertisement. We evaluated free school meals. We looked at mobile phone use and brain cancer and all these kind of things within the broader context of the center. What I do have to say is that I'm quite enthusiastic about this, so I can talk about this well, but then they don't work all the time. So they are quite difficult studies, and there's certain situations where they work. This is great. Certain situations where they don't work, and it's very difficult to do these kind of studies. You need to know when and where to do that. And one of the important things is to combine them with qualitative research and process evaluations, so that you get a very good idea of what's going on and you know everything about the context of them, and you can put the numbers you find in context. I still don't know a lot about it, so I'm not going to talk about this. I'll leave that to others when it's their inaugural lecture in a couple of years. But I would like to talk a bit more about these kind of evaluations and what the problem is with them and why they're difficult to do. And that to some respect lies in this figure. So that's if we take a step back to 1985 to an eminent professor from London School of Hygiene and Tropical Medicine, Professor Geoffrey Rose, who wrote a book, Sick Individuals and Sick Populations, and this is an important figure from that book, or from that article initially, and it describes two population approaches to reducing health problems. One is the blue one, the risk reduction approach, and what that means is, say you're interested in alcohol misuse and health effects, you identify the people in the population that drink a lot, or too much, or that smoke too much, if that's your interest. You target them specifically with interventions, and then their risk, the light blue bit, will go from high risk to medium risk. That's one approach. One other approach is the population approach, which is more or less the whole blue curve. And instead of targeting people, you do a low intensity intervention to the whole population, and for example, anti-smoking campaigns, or sugar tax on soft drinks, for example, that target everybody. Most people won't bother with that, but some people will reduce their intake as a result of that, and that's across the whole distribution that you see there. And as a result, the whole distribution will go from switch from the right end, the higher risk, to the lower risk. And there are situations where that's a much better approach than only identifying the high-risk people. And the kind of interventions and policies I'm interested in are these kind of area-based or place-based interventions that do exactly that. So they have a low-intensity intervention for the whole population. The problem with this is most people don't react to that. The way you do your analysis is that you have to average this out over the whole population. So you find very small average treatment effects or average population effects. And when you're very small to a null effect, and you're trying to discover small things in large complex populations, it's really easy to do it wrong, and that errors cause problems, and that you say that something works when it doesn't, or you say something doesn't work when it does. And so that's why these things are difficult, because you need to try and identify average treatment effects that are really, really small across the whole population. So these small errors that cause these kind of problems, there's quite a lot of them. And you can have wrong causal models, problems with the data, residual confounding type issues, p-hacking, and there's loads of other problems that can be an issue, but they're all highly technical and specialist, so I'm not going to talk about that here. What I do want to talk about is more general approaches to how you make these things better, and things that should be done in these kind of studies. And the first one is, and this may seem self-evident, but it's not necessarily, is that you want your evaluation or the effect that you observe, you want that to be unique to the time and the place of the change of the exposure. So when somebody brings in a new intervention and you find an effect, for example, you want to make sure that that effect only occurs in relation to that particular intervention and is not some kind of effect from somewhere else. So when I go back to that alcohol licensing example, there we did a lot of falsification analysis where we programmed in areas where nothing changed and looked if we indeed found nothing, and we changed the time points to see if we indeed would find nothing, and we would only find an effect for the right place and the right time, which is exactly what we did find. And that's why these kind of additional analyses are really important. A second one is to make sure that you have a control area or a control group in your study. You don't necessarily have to, but the risk if you don't do that is, for example, if you're looking at a long-term effect of an intervention and a COVID-19 pandemic happens and you don't take that into account, so you don't look at what happens in areas where nothing changes, then you inadvertently assign part of your effect that you claim that there is actually due to something completely different. Finding these controls, these controls have to be exactly the same as your intervention area in all but the intervention to make good causal claims. And that's really difficult, and sometimes you can't really identify whether you have a good control. So what you can do is find different controls or different sets of controls, and then compare it across these different sets of controls and see if you always find the same result. So one example of a study we did is the communities in charge of alcohol in Greater Manchester. So the idea there was that they trained local so-called alcohol champions, so people in the local community who would help others with alcohol misuse problems, or who understand how the alcohol licensing system works and can then influence that to try and reduce the area level of that. So that we did a large intervention, and that intervention was led by the University of Salford. But we in Bristol did the numbers, so to speak, so we did the quantitative evaluation. When we started this, we anticipated that at the very best, this would give us a very small average effect, because you can only train so many alcohol champions, and they can only do so much in a certain time frame. So to make sure that we minimize the probability of making really heroic conclusions that turn out to just be wrong, what we did is we included a comparison of 3 different types of controls, and we used 4 different types of analysis so that we could compare it all across all these different ways. And one of the analysis we did was all these alcohol champions were trained at different points in time. So each SICA area is what we called them, so each intervention area had an intervention at a different point in time. So for those in the know, if you have a step wedge, it's called a step wedge design, and you compare what happens before and after across all the areas. Then we compared with other local areas in Greater Manchester that were similar in all respects to the intervention areas, but didn't receive that intervention. And we did the same thing, so a third set of controls was a comparable local area anywhere in the country, but in Greater Manchester, just to make sure that we made this additional comparison as well. So when we did that, we found effects here and there, but overall, when we triangulated this all across, there wasn't any evidence of a measurable effect. And that makes sense, because all the qualitative evidence we have and the process evaluation told us that there were problems with the fidelity of the intervention and with the magnitude of the number of alcohol champions that could be trained. So that you wouldn't expect an effect once you know that. And had we not done that, had we not done all these extra analysis, we would have come up with some really heroic conclusions that were just wrong. And now we know exactly why it didn't work, why there wasn't a measurable effect, and what to do about it. So that's the importance of doing all this extra work. Another analysis led by colleagues, and I promised I wouldn't name names, so I shall not name names, but they're there, was the evaluation of the IAPT service, or the Access to Psychological Therapy service, with an enhanced component of well-being support and community service links. And the question was, this enhanced bit, does that increase the clinical input or not? So we had two complementary analyses. One where we compared all the patients who received this enhanced service with a matched group of patients from somewhere else in the country where that service doesn't exist, so that we can compare across. And the other one was with a matched group of patients from the same practices that received the enhanced version, but before the enhanced version existed, so an earlier set of controls. What we found was no effect of the comparison with the other area, but what we did find was an increase, a decrease in anxiety from this, because what that turns out to be is, what we think it is that the enhanced bit doesn't actually add anything measurable to it. So, but that over time, this IAPT service by itself has gotten better, which is quite an important finding in that respect, and quite reassuring, I would imagine, for the people doing that. So these are the kind of analysis, and this is and we're doing this right now. This is the kind of research we do, and we want to make that as good as possible. And this is an example of an evaluation we're doing now of the Bristol outdoor advertisement and sponsorship policy, where as part of School for Public Health Research work, we were involved in a study led by the London School of Hygiene and Tropical Medicine, where we looked at a similar policy implemented by Transport for London, where basically you can't advertise junk food anymore, and whether that has an impact on how much people buy of these products and consume. And we did find an effect there, and Bristol was the first city outside of London who did that, so we were really interested in doing that here as well. So we did that with a study of University of Bristol, London School of Hygiene and Tropical Medicine as well, and Leeds Beckett University. And we are in the process now of a really comprehensive evaluation, mixed methods with a lot of interviews, focus groups, but also health economics eventually, and a whole quantitative evaluation. And for that quantitative evaluation, we're comparing two different supplementary kind of outcomes that we're interested in. But we also use 4 different control areas matched to the Bristol population, so that any effect we find, if we triangulate across all these analyses and groups, will in all likelihood be the result of that policy and not something else. So we're at we have another year or something like that of doing these analysis. So if you're interested in this kind of thing, keep an eye out on the website, because we're kind of doing that. Now, so that's 2 simple things. You can take this whole, how do you control for all these things in evaluations? You can take that one step further into something called quantitative bias assessment. And I won't go into details too much here, but the idea is that you have a study, you've done your study, but you have identified limitations to your data set, so problems with your data set, and or with your study design, and you think about different scenarios, how these problems can occur, and then you explicitly model these in, and you see what the impact is on the results. And if that doesn't change your results, you know that your study was very robust to the to whatever was not ideal in your study. And if that isn't the case, you need to think about whether you can make any strong conclusions. So this is the only sciencey bit I'll present in my talk. This is from a study that we did on low dose and low dose rate radiation in nuclear power workers in England, and whether that had an effect or a cardiovascular effect. And that's quite an important thing, because currently in radiation protection, only cancer is included, but if this has cardiovascular implications, there's a whole new ballpark to consider. So what we saw is that, it's the blue line, the thick blue line is the main dose effect curve, and we did find an association between the two. So there is an effect from about, say, 300 millisievert. It doesn't really matter what that is for this talk. But that association existed. But there were a couple of problems with the data set. And for example, just to pick one, and that's what this figure is about, is smoking history was missing for quite a large part of the cohort. So we thought about different ways, like how can that be missing? And for example, it can be missing random, but it could also be, which is not unlikely, that heavy smokers don't answer to their occupational physician, what they really do, or not at all. And then you have a certain way of how that feeds into your data set. And we came up with 4 different scenarios, how that could work, plausible scenarios. We programmed that in, and then we generated, and you can't really appreciate that here, but we generated 1,000 new studies with new data sets to see whether the overall association changed or not. And that's all the gray lines. And you can see that there's some difference between the different scenarios, but overall you continue to see the same effect, which makes us quite convinced that there in all likelihood is an effect. And we did that for lots of the factors that we wanted to look at extra, and none of them actually changed anything. So we argue from this study that there probably is an association with cardiovascular, so ischemic heart disease, and cerebrovascular disease in particular. So this is not a natural experiment study, but the same principles apply to a natural experiment study. I haven't really seen this kind of work being done, and I think it should be done more often. Now, what I've been talking about so far, and all these extra analysis, to many people here, especially people online probably as well, it's probably quite obvious, and you think, why wouldn't you do that? Why wouldn't you check all these things? So we did a study as part of the School for Public Health Research, where we did a review of more than 350 place-based public health interventions, and we looked whether they did these kind of things. And this is taken from that paper. These are different methods. It doesn't really matter that much, just if you know what the methods are, it might be of interest. But on average, any kind of falsification analysis was actually only done by 50% of these kind of evaluations. So that's quite a lot of improvement. And given that they're place-based, you'd be interested in both time-specific and place-specific. Only about 10% of the natural experiment evaluations did that. So it might seem obvious to us, and I hope I'm talking to the converted here mostly, but if you look at the wider literature, that isn't actually the case. So that begs the question, why isn't this done? Because if you think about what we're all taught in relation to science, philosophy, and Popper, is that we need to falsify our hypothesis. So we need to try and disprove it, and if we can't disprove it, it's probably right, is the in a nutshell. But actually what most of these studies are doing is proving that something is correct, or inferring that it's correct from an analysis. And the question is, why would that happen? So from a researcher's perspective, it's just easier to publish. It's It's easier to get follow-up funding. It's better for relations with stakeholders, these kind of things. It also shows more impact, and we all need to show impact from every single study that we do, whether there is any or not. Importantly, it's the kind of studies we are interested in. So the finding aligns with what we think it should do, both because our prior beliefs, but also because we're convinced that that's a good idea, or because of our worldviews, thinking, okay, this is what should happen. And that's quite an important thing. And the same, in a way, goes for other stakeholders involved in the implementation of policies. They probably have invested quite a lot of resources and political capital, for example, to get to this stage in the first place. So if it's evaluated, it's much more appealing to have an effect than it is to say that you couldn't find anything. And again, this aligns with the idea of that it fits into what you've been taught and fits into the worldview of what should happen. So this kind of, in a way, unconscious error is something that exists and is well known in relation to industry, and it's called industry bias. And the idea is that industry tries to influence science where it involves in effectively their profit margin. And there's quite a lot of study on that, quite a lot of evidence initially from the tobacco industry, but it's also involved in alcohol. There's evidence from fossil fuels, there's evidence of climate change. And that's quite well documented, and there's quite a lot of research around these kind of things. And it's very, very important to keep an eye on that and to investigate that. But that's not what I want to talk about. I want to talk about here about the mirror image of that, which is effectively the same idea, but it's a type of investigator bias where it's called white hat bias, and the idea is we're public health researchers, and we want to improve public health. So if we find stuff kind of, that tells us that we're doing the right thing, we are possibly a bit less critical in that respect. And it's kind of best described as an unconscious way of, when you're doing evidence synthesis, that you accept lower quality evidence when something aligns with what you think should happen, and you reject evidence that shows the opposite. There's evidence of selective use of studies and of scientific ideas, something called cherry picking that you may have heard about. So this white hat bias is for the first time described in nutrition and obesity research, but it's been shown in quite a lot of other areas as well. So around COVID-19 research, environmental sustainability, substance misuse and breastfeeding. And currently there's a whole discussion where this feeds into around ultra-processed foods as well. The problem with white hat bias is that hardly any research is being done on it, possibly for obvious reasons, and so we don't know what the impact of it is. So we did some research in that. So I mentioned in the beginning that my interest, one of my interests, is around radiation protection, and we looked at the first 5 years of reviews and evidence produced around 5G mobile phones and possible health effects. And we looked at who did these studies, what were they affiliated to, what kind of study methods did they use, and how would that feed into any form of industry bias or white hat bias or anything else. And when we did that systematically, what we found was aligns with white hat bias, where we found that those researchers with links to NGOs or activist groups just used lower quality of evidence and did a lot of cherry picking in their reviews and their evidence synthesis than either independent researchers who hadn't any link to industry or NGOs, but also then industry researchers who actually did use quite systematic approaches. So that says nothing about whether 5G causes any health effects, of which I have my own opinions, but luckily the topic of my lecture is not about that. But it does say that this kind of the research coming from these NGOs, coming from these activist groups, is in all likelihood much more biased in its description and distorts the literature about that. So white hat bias is a play there. And the problem is, like industry bias, it's very difficult to address that. For white hat bias especially, because it would basically be us as a public health community investigating ourselves and probably make you a bit less popular amongst your colleagues. So it doesn't happen a lot. And another thing is that in some of the research, or some of the areas more related to say, NGOs and activist groups, non-industry conflicts of interest are actually not considered conflicts of interest, which is a problem. Some things are being done about it, open science principles where pre-registration of your studies, etc., and registers of conflicts of interest. So there is work being done in this area that starts to make a difference. But given how important this is and how nefarious, not enough in my view. And one of the reasons I think, which I'd like to flag near the end of my talk, which is I think is an issue, is the lack of accountability that we as public health academic researchers have. We're not, in contrast to a clinician, for example, or an engineer, when we do a study and we do something wrong, barely ever affects us really. If anybody could ever find out that it was wrong to begin with. So that relates to the title of my talk. We have really no skin in the game, which causes problems in the interpretation of that. So I thought about a very simple, very easy thought experiment, which I think which I'm using, and I think others could be using as well. And it's the idea: what if it was our own money? Which might be very revolutionary to some, but what if we do an evaluation and we then invest, and we had to invest our own money into this? If we think it works, we invest our own money. If it doesn't work, if it does work and we were right, we get our money back, or possibly even a profit. But if it doesn't work, then we don't get it, we lose all our savings and possibly have to pay a fine. Would that change? Would that change how we do our analysis? Would we want more falsification analysis? Would we want more sensitivity analysis? Would we want to do any of these checks? And I very much think that we would do these checks. And I think we need to think a bit more about these kind of things. And we have to convince ourselves, and I think this thought experiment goes a little way in thinking about that. Now, everything I've said, none of that is novel, I have to say. Other people have made more or less the same points along the way. And in relation to natural experiment evaluations, we're currently rewriting the guidance on how you should do that. So there will be new MRC and IHR guidance that we're developing together with Glasgow, Exeter and Cambridge, and we hope to have that published soon, which targets some of these things a little bit. So we are moving forward. So then at the very end, because I'm nearing the end of my talk, I want to echo the point made by a lot of other people before, never heard by as many people as should, around the fact that better methodologies lead to better evidence, and better evidence leads to better policy. And hopefully we can make this better. So the first thing we can do, we have to start with ourselves. That's why I wanted to talk about this particular topic. We have to make sure that we don't fool ourselves, and that's a first step. We have to convince ourselves that our research is correct. Because if you think about it, if we don't fool ourselves, we get better evidence. Basically, given that we are in public health or environmental health, better evidence leads to better population health, and we are population too. So in a way, we always had skin in the game anyway. We just need to make sure that we are aware of this and that we keep thinking about that when we do our studies. That was all the science bit of my talk. We're getting nearer to drinks, but I do want to say a couple of thanks. First, all of you and people online as well for being here, not leaving halfway. So it's really nice to have so many people here, and also so many people that I know listening to what I have to say. It's generally that doesn't happen, so this is quite nice. And then I would like to thank Sarah Wayman specifically, because she helped me organize this whole event, and by help me with, I mean she kind of did all the work and I just did the presentation. So thank you very much. Then I would like to thank all my colleagues that I've worked with from the university and abroad and other parts of England. I genuinely enjoy working with everybody, which makes me slightly worried here, because every office, as far as I know, has someone in it that nobody likes to be working with. Now, I can't identify somebody, which makes me slightly worried that it might be me. If that is the case, I'm very sorry. If it isn't, then I hope we can continue to work together. Then, specifically, I want to thank Rona Campbell, who's been my line manager for 9 out of the 10 years, and who's always been there with a lot of help and advice. So thank you very much. And effectively was the one who guided me into eventually becoming a professor. So that was great. Thank you very much. Then everybody who's been involved in all the studies that I haven't mentioned. So thank you for your collaboration on that. So they couldn't come here, but prior to working in Bristol, there were 2 people who influenced my thinking and my research quite a lot. The first one, Professor Hans Kromhout from Utrecht University, who was my PhD supervisor, and we've continued to work since that period together. So he's had quite a lot of influence on how I think about things and how I do things. And the other one is Professor Raymond Ajus from the University of Manchester, a very dedicated occupational physician who's still fighting the battle, despite being retired, still fights the battle of worker health in relation to COVID, who was quite an inspiration when it comes to this kind of motivation and the drive to wanting to do stuff. And then finally, I want to thank, on the front row, my friends and my family who made it over here, all the way from the Netherlands. 2 of my friends made it over, which is great. So thank you for all this. Then, last but not least, 3 people in, I suppose, order of appearance. My wife, Kim Hannum, who is a Coast Guard, as you can see, but some of you will also recognize her because she's a public health researcher at our department in her own right. She's actually much better in public health research than I am, but she hasn't just had the opportunity yet to show that to everybody, mainly for 2 reasons. This is the first reason. My daughter Sophie, who's here in the front row, who is quite more important to me than she thinks, because she asks a lot of questions, a lot of very difficult questions, and she does not accept nonsense answers. So it keeps me in my toes wherever I can. And then lastly, you may thank my son, who isn't here, because if he hadn't been there, it would have been a much longer presentation. There would have been a lot more slides, and it would have gone well into your drinking time. So with that, thank you very much for your attention, and thank you very much for staying until the end. Thank you.
Good evening, everyone. For those of you who don't know me, I am Rona Campbell, Professor of Public Health Research at this university. I lead the Centre for Public Health, where Frank is based. And it's my honour this evening to formally thank Frank for his wonderful lecture. But before I do, I also want to say hello to Frank's family and to thank them and his friends, and to thank them all very much for coming here this evening. I'm sure that you are all very proud of Frank's achievements and the very thoughtful lecture that he has just given to illustrate the research that he does here. Frank's colleagues are also proud of his accomplishments, and we are delighted to have this opportunity to celebrate him achieving his promotion to a personal chair. Public health research is a very broad field of research and practice, but it has three distinct branches. Firstly, health protection, which involves protecting populations from infectious disease and environmental hazards, including radiation. Secondly, health services public health, which focuses on the efficient and effective delivery of services which maintain public health. And thirdly, public health improvement, which seeks to prevent ill health and reduce inequalities. Academics tend to focus on just one of those areas. But Frank's a bit of a public health polymath in that, as his lecture has shown, his research spans all three. What's also very commendable about Frank's work is that while it has a strong methodological focus, which may seem very academic, the intent is always to answer very practical questions about what can be done to improve public health, and often, as you've seen, at the very local level. As a university, Bristol prides itself on its civic engagement, and the work that Frank presented here today shows beautifully how world-leading methodological research can also serve improving the health of population of this fine city and many other places, because as you saw, quite a lot of the work Frank described was done actually in Bristol. Another impressive thing about Frank is that although he is a prolific author of academic papers, he is also very keen to share his work with others in a practical way and to improve the standard of research using natural experiments. And to that end, with the support from the School for Public Health Research, he set up and leads a very successful network on natural experiments, which hosts regular events to educate other researchers and debate the finer points of the methodology. But Frank's not only a very accomplished researcher. As we know from his students, he's also an excellent teacher. He makes a very important contribution to the undergraduate medical curriculum and to our centre's very successful MSc in public health. He is also an excellent PhD supervisor and looks after and appropriately mentors the members of staff for whom he is responsible. Within the Centre for Public Health, there are some values which are intrinsic to the way we work. These include aiming to bring about change for the better, both in terms of public and planetary health and reducing inequalities. Empowerment, which is about not undertaking research on, but with people and communities. Transdisciplinarity, because to solve the immense challenges within public health requires expertise from many disciplines. And collegiality, because public health research is team science writ large. As scientists, integrity and impartiality are, of course, also key. Frank embodies all these values, as his lecture and what I have told you about him illustrates. But as the thesis of Frank's lecture also indicates, such values must be examined and not taken for granted, because clearly as public health researchers, we're not always as impartial as we'd like to think we are. So Frank, we thank you very much indeed for your inaugural lecture this evening and congratulate you on achieving your chair in epidemiology and public health.